very poorly controlled ice syndrome. And I've been trying to get her around to the idea that she's safer in the operating room than she is going to the grocery store, which is true. Mm-hmm. But, you know, try to tell somebody that. Our surgery center, the surgical center that Sahar knows very well, is completely distinct from the hospital. Now, if they had to come to the ED or something, that would be a different story. Then I would say, you know, I mean, I won't go near our ED at the moment unless I was on death's doorstep.
Well, listen, I think we'll get started. Thank you, Harry, for just giving us an update about your garden and also what's happening at Hopkins. I want to hand it over to Jeb. Jeb Ong has been running these rounds and has been organizing things. So, Jeb, if you want to get the ball rolling, we've got 3 great presentations, and we've got a great group of panelists. We're on Zoom here right now. We're also live on YouTube. Some of you find that the videos on YouTube are perhaps a little bit easier to see. So you're welcome to join on Zoom or on YouTube. The advantage of being on Zoom, of course, you can ask questions of the panelists as well. So you'll feel free to join on either means. And of course, I think everybody is now very accustomed to online learning and webinars, and this is no different. And we'll try to make it as interactive as possible. So Jeb, I'll hand it over to you. Thank you. Jeb, you there? Or we lost Jeb, maybe.
Whoops, sorry. Can you hear me now?
That's what normally happens when we're in rounds with Jeb, by the way. He's usually speechless.
That's not true. Okay, so thanks everybody for being here. Again, just a few quick things. Our website is www.prismeinstitute.com/webinars. For any questions, comments, please email them to ike.webinars@prismi.ca. This next slide here is really just a reminder in terms of the type of presentations we're looking for. Again, it could be a lecture, a case, or an article that you wish to review. If you want to express interest, please email again to that same email address. Our website is now fully upgraded and up and running. So previously recorded webinars are now on there, and you can also register for future webinars. So please make good use of that starting now. And this Saturday, we're going to have Dr. Nir Shoham Hazan, who's going to be talking about reactive or proactive, a case of challenging glaucoma management. And then Dr. Ike Ahmed is going to be talking about IOL dysphotopsia got you down, how to fix the unwanted. So again, this is on April 18th at 12 o'clock Eastern time. So our first speaker today is Dr. Adrian Tang. He's the Chief Ophthalmology Resident at the University of Ottawa Eye Institute. He did his medical training at the University of Ottawa. On his panel, we have Dr. Harry Quigley, who's an Edward Momini Professor of Ophthalmology. He developed the glaucoma division at the Johns Hopkins Wilmer Eye Institute. He was a founding member of the AGS. He's published over 400 peer-reviewed articles and has trained at this point 65 glaucoma clinician scientists. So needless to say, we're very honored to have him here today. We also have Dr. Gary Miller, who's an assistant professor of the University of Ottawa Eye Institute. He's a previous glaucoma and advanced anterior segment surgeon fellow with Dr. Ike Ahmed, and he did his residency at the University of Toronto. Next up, we have the inspiration and the source of the COVID hair challenge himself. We have Dr. Ike Ahmed, who's the division head of ophthalmology at Trillium Health Partners. He's also the director of the GAS Fellowship. He's also an assistant professor at the University of Toronto. And on his panel, we have 2 very special doctors here today, affectionately known as the GAS Girls. We have Dr. Tiziana DiFrancesco, who's a current GAS fellow at the University of Toronto. She did a previous GAS glaucoma fellowship at the University of Campinas, and she did her ophthalmology residency at OLA. And we also have Dr. Valentina Lozano, AKA Gator Eye Surgeon, current GAS fellow at the University of Toronto, and she did her residency at the University of Florida. And for those of you who have not yet partaken in the challenge, join the COVID Hair Challenge. It's for good cause, conquercovid19.ca, essentially trying to get PPEs to the right places so that we can take care of the right people. So go ahead, and if anything else, it's just fun, so do it. Okay, our third speaker, we have Dr. Sébastien Gagné, who's a medical director of the Institut de l'Œil des Laurentides in Boisbriand, Quebec. He's also an assistant professor at the University of Montreal. He did his GAS fellowship with Dr. Ike Ahmed as well, and he did his residency at the University of Sherbrooke. On his panel, we have Dr. Zeynep Aktas, who's joining us all the way from Turkey. She's an associate professor and director of the glaucoma unit at Gazi University. She did her fellowship at the University of Wisconsin, and she did her residency at Gazi University as well. We also have Dr. Sahar Bedroud, who's a glaucoma and cataract specialist at Acuity Eye Group in Pasadena, California. She's an assistant professor at USC Roski Eye Institute and Los Angeles County Medical Center. She did a glaucoma fellowship at the Wilmer Eye Institute. She did an ophthalmology residency at the Doheny USC Roski Eye Institute, but she also did an internal medicine residency at the Huntington Memorial Hospital, which means that unlike the rest of us, she's actually a real doctor. And with that, I'm going to open it up to our first speaker, Dr. Adrian Tang. You can go ahead and start sharing your screen, Adrian.
Thank you very much, Jeb. And I want to thank Dr. Miller and Dr. Ahmed for inviting me to speak.
And thanks, Adrian, for presenting, and thanks, Jeff, for the introduction. I did want to again welcome the panelists, and you're of course welcome to participate in all the cases. We just wanted to assign people to know that we're going to count on you, but because this is of course multidisciplinary, and we have a lot of different topics here. Everyone has different expertise, but a bit glaucoma focused here. Please join in on some of the discussion. So thank you, Adrian.
Perfect. Thank you very much. So first off, we have a case of low pressure or low perfusion glaucoma. I have no disclosures, and those are the disclosures of Dr. Miller, my supervisor. So just a little bit about what normal intention glaucoma is. It's a type of open angle glaucoma. And typically all of these patients always have IOP measurements that are consistently lower than 21 millimeters of mercury in our clinics. The visual field loss that they have is usually greater than expected based on the appearance of their optic nerve. And the scotomas are usually deeper and closer to fixation. There's also more localized defects on the retinal nerve fiber layer. Another characteristic feature is the propensity to have optic disc hemorrhages. The collaborative normal tension glaucoma study told us that patients with hemorrhages are 2.72 times more likely to have progression. The other risk factors for normal tension glaucoma are migraines, obstructive sleep apnea, ischemic vascular disease, diabetes, thin corneal thickness, and hypertension. And you'll notice that a lot of these are systemic conditions and not just of the eye. So the case that we have today is a 67-year-old male, and he was referred for rapidly progressive glaucoma in the right eye more than the left over the past 3 to 4 years. His pressure had always measured in between 10 to 12 millimeters of mercury consistently at all his visits, and his max pressure had only been 16 in both eyes. His ocular history is significant for strabismus surgery in the right eye, vitrectomy in his left eye for an epiretinal membrane, and he also 15 years ago had clear lens extraction and LASIK to both his eyes. His past medical history is interesting in that he has hypertension, but he also has renal cell carcinoma. Around the time of the consult, he had a nephrectomy. The meds that he's on is irbesartan, which is an angiotensin receptor blocker, hydrochlorothiazide, tamsulosin, and aspirin. His ocular exam, he had visual acuity was 20/25 in the right eye, and he was 20/20 in the left. He was only on bromonidine, and his IOP was 10 and 11. His corneal thickness is near normal. His corneal thickness is near normal at 560 on the right and 520 on the left. When we looked at his discs, he had peripapular atrophy in both eyes, no abnormal pallor, and no disc hemorrhages were seen. And also his color vision was normal. So these are his automated visual fields, 24-2. Kind of when he was first being seen by one of the other ophthalmologists, this is his right eye with you'll see the central defect. And then by the time he was referred to us, that central defect was getting worse. And you'll see that on the trend-based analysis of his visual field index, that there's quite a significant slope downwards. The left eye, we can also see that there is the central defect with some progression. The trend-based analysis shows that the slope of visual field index loss is less, but it is certainly still happening. So I guess this is kind of here where I wanted to ask the panelists what they might have done next, or what are things that we could do to help this patient initially.
You want us just to jump in?
Yeah.
Okay, well, first, your lead-in in the world literature is, I think, partly accurate and to some degree continues to express prejudices that have been adequately killed by actual real data. The early manifest glaucoma trial took a look at population-based glaucoma patients followed over time who were not being treated. And among the risk factors, all the cardiovascular risk factors were not associated with progressive change. So things like migraine and coronary disease and hypertension itself are not necessarily associated with glaucoma, whether the person had a higher pressure glaucoma or a lower pressure glaucoma. Certainly disc hemorrhages are more likely to be seen. I take it you didn't mention, so this fellow probably didn't have any disc hemorrhages that had been detected. One of the things cardiovascularly that is highly associated is a low junction between the blood pressure and the eye pressure. This came up first for us in the Baltimore Eye Survey, and it's been confirmed in nearly every population-based study of glaucoma that's ever been done, namely that a lower difference between the mean blood pressure and the eye pressure is more likely to lead to the prevalence of glaucoma and the progressive worsening of glaucoma. Interestingly, this guy's on losartan, which in mice is protective in glaucoma. We did an experiment that showed that. And there's a recent very nice study from the Netherlands that actually has confirmed that among all the hypertensive medications, the only one that seems to be protective for glaucoma is losartan or irbesartan in that group of medicines. Losartan and irbesartan are actually slightly different, but probably the two share some features. This guy had LASIK, and his pressure, his corneal thickness is still normal, which is kind of interesting. So he must have had thick corneas to start with if they actually shaved some of it off. And when you see a pattern like he has in his right eye, there's no question we need to do something for him. The first might be to find out if his eye pressure is actually higher at different times of the day. Poor adherence, higher pressures away from the office visits, which can be done with home eye care measurement or with having him buy an eye care tonometer and using it at home. Those are nice ways to get at that. Certainly he's got plenty of room for more non-surgical therapy. And I think we probably should be pushing all of those for him in terms of lowering his eye pressure and making sure he doesn't take his blood pressure medicine late at night. He should, if he really has hypertension, he ought to be taking that medicine in the morning when the blood pressure is at its highest peak and not taking it at night when he'll drive himself into those nocturnal dips. I'm sure the other panelists have other things to say.
Yeah, so that's kind of similar to what what we did was we did increase his medical therapy. So we put him on the combination of carbonic anhydrase inhibitor as well as an alpha agonist, and also we added a prostaglandin. We also did selective laser trabeculoplasty in both eyes, just in case that we were missing increases in his IOP that weren't showing up in clinic. We also asked the patient to sleep with his bed, with the head of his bed elevated, so as to decrease possible IOP spikes at night. So
Adrian, I wonder if I can just interrupt for a second and just ask the panelists, I mean, of course, we can open a Pandora's box with regards to the mechanism of how glaucoma disoptic neuropathy occurs and talk about mechanical, vascular, immunological, and all the other types of theories that have been purported to progress in terms of nerve damage. But I'm just curious about talking about the perfusion aspect of it. And Harry touched on it as well, as far as looking at ocular perfusion and the Baltimore study, and others have kind of shown this. Do you adjust your eye drops to consider this, considering we know that some of these vasoactive molecules can vasodilate or reduce systemic blood pressure? Does anybody look at that aspect in terms of addressing it in these cases where we think perhaps this is what's going on, or in general?
I guess for me, obviously this is a patient of mine. I definitely like to avoid beta blockers for these patients. And, I also wonder about I know sort of pros and cons with respect to brimonidine, but I guess some questions about how that might affect blood pressure as well. But, I do, in these scenarios, try to do everything possible to lower the pressure in a way that I can avoid having an effect on the blood pressure, especially at night. So that's essentially the way that I look at it and try to max out those medications. But definitely the carbonic anhydrase inhibitors I think is usually beneficial and can have some benefit at nighttime. So I always want to make sure a patient has that on board.
What about the others? I mean, should we be avoiding certain glaucoma drops for certain glaucoma? Is that a factor you think about in terms of its impact on blood pressure?
I ask my patients if first, if they have high blood pressure, low blood pressure. Oftentimes these patients will be taking something for high blood pressure, and I will, with conjunction with their PMD, ask them to take it in the day or in the morning so as to avoid the evening low kind of vascular perfusion to the nerve. And I would consider taking them off the timolol or any beta blocker. But that's usually kind of like my last resort. I don't know if it's actually doing anything for them, but I do want to kind of avoid it at all costs. So I will put them on everything else, but the beta blocker, and ask them to change their hypertensive drug regimen a little bit.
The average patient is taking 50% of their eye drops. And we've demonstrated that, unfortunately, in electronically monitored use of glaucoma pressure lowering agents. So a first step for everybody who's in this guy's situation is in going through with him the importance of adherence with therapy. We have ways in talking to patients of asking them the question, do you think in the last 2 weeks, maybe you missed your drops even once? And you even might open the door by saying, you know, I take up blood pressure medicine every day too. And I even notice myself missing it once in a while. What you're doing is you're, as the doctor, opening the door to saying, everybody misses once in a while. Do you think you do? Now, if they say, oh no, doctor, I'm religious, I never miss a drop, then you actually don't know what their adherence is. They could be good or they could be bad. If they admit to even once in the last 2 weeks not taking it, the average adherence of that group of patients is under 50%. So this is a guy who either needs better adherence, if that's the case, or we'll go on to what one of the chat questions here has already said, which is this is the patient who probably needs to have a trabeculectomy, whether he's adhering or not. He needs to have quite low pressure and will probably tolerate it reasonably well, as many such patients do. I would have him have a blood pressure cuff at home. He ought to be measuring, if he's not already measuring his blood pressure at home, we ought to know what it is and how variable it is on every day.
Absolutely.
Gary?
I can just make a couple comments. This gentleman was, did seem quite reliable with respect to taking his medications. I believe he's actually one of those patients, and we see them more and more now, who will actually put a reminder on their smartphone in order to make sure that they're taking the drops. In addition, definitely was taking blood pressures at home in conjunction with his internist. So was definitely keeping track of that closely.
Is it worthwhile? I mean, Zainab, would you want to get like a 24-hour blood pressure on these patients? That I'm grouping them again, and I know we got to be very individual, but let's just say in general, patients who are progressing at pressures that we think are normal, quote unquote. Does that enter your equation? I mean, the role of 24-hour blood pressure and monitoring and measuring it?
Yeah, I totally agree. That's what I usually do in these patients. Because I have a couple of patients like that, and nocturnal hypotension, that I saw nocturnal hypertension. So nocturnal hypertension is very important in terms of progression of disease. So I would like to see 24-hour blood pressure monitorization in those kind of patients. I totally agree. I believe it's very important.
I guess the question comes up if you do get, patients who dip a lot at night, and again, it's a whole other story about how compliant they are. We talked about compliance with glaucoma medications, which are typically the worst of any medication taken by a person. But antihypertensives are also up there in terms of poor compliance as well. And then you enter that in the equation, you got fluctuation and everything else. A lot of things are mixed in there. But does anyone actually, would anyone actually, because we talk about it a lot and we talk about it being a risk factor, and multiple studies, have revealed this, whether you measure it by mean ocular perfusion or diastolic ocular perfusion, whatever way you measure it. Most studies have shown the correlation. And this isn't necessarily only with north-pressure glaucoma, by the way. This is for high-pressure glaucoma as well, this quote unquote. But do people actually do this and actually stop blood pressure medications? Is that a practical thing? I mean, this is a practical question people ask. We measure it. What do we do with it? I mean, would any of you actually consider withholding or stopping a blood pressure medication? Does it add any more information to you in terms of managing this patient's glaucoma?
Actually, I think if you're able to put in the evidence that the patient is a night dipper or he has significant low blood pressure at night, then it's interesting to talk to the family doctor to inform them about their condition and that their glaucoma may be partially progressing because of this poor blood pressure control. And with the family doctor, I usually advise them to maybe check for a different kind of medication, or if they really need that medication. And then we do a 24-hour blood pressure control after, once the medication has been adjusted.
So Harry, I want to ask you, Harry, I mean, we talk about it all the time, and the people in the chat group are asking, should we be asking about hypertension? Should we be stopping blood pressure medication? Should we give them salt? Are we kind of just spinning the wheels here? Should we just, listen, I mean, that kind of stuff is how valuable is it? And should we just be going to surgery? What are your thoughts, Harry?
Well, I've discussed it with internists and with the patient on maybe a dozen occasions. Can we possibly try to stop one or more? This guy was on, if I remember the med list, he's on HCTZ and irbesartan, so he's on 2 drugs.
Yep.
He is, however, somebody whose kidney just got taken out, so there must be some potential worry that he's going to have something go on. I assume they left his adrenals when they took the kidney, but I don't know that if the cancer involved the adrenal glands. So this is a more complicated situation than the average sweet old gentleman who's on 4 kinds of blood pressure medicines. When we've done this, it turns out that they almost never need all 4 of the blood pressure medicine. What happens is they get put on medicine 1, they don't take it, they show up with a blood pressure that's not good, and the doctor, instead of talking about adherence with therapy, starts another medicine. And they wind up actually supposedly taking 4 medicines, none of which they're actually taking reliably. One of these patients I had who was admitted to the hospital, they actually delivered all 4 glaucoma meds as this woman was admitted to the hospital for something else, and she stroked from having those medicines actually get delivered to her. So I think there are a lot of the medicines you could stop and they don't have any effect, and we've stopped them sequentially on some people until we got to either they almost didn't need anything or they needed just one of the medicines. I think that still is not going to get us out of needing to do something for this patient. This is somebody who over a 4-year period or so, if I could read the graph properly, has been going downhill in the right eye. So while short term we can say, let's do this, let's do that, I think we need to act more definitively to get the pressure lower. And I'll grant you that there's a 5% chance of hypotony maculopathy doing that. But this is somebody who's going to heck on a handcart, and we need to change the game in at least the right eye.
Mm-hmm. But I think it's important to make the proper decision before going into surgery if the damage is solely attributed to pressure, IOP, or it's attributed to poor perfusion. If the systemic perfusion is a problem, then maybe you can advise your patient to be more compliant on the drops. But for me, it's not an eye disease per se; it's a systemic disease and needs to be addressed.
Well, I don't think that this person has a systemic disease. He's got hypertension and he's got kidney cancer. So we already know that. The question is, can we do something that could safely raise his eye pressure to raise the perfusion pressure? And there is a medicine that's FDA approved in the United States that is said to raise blood pressure for people with symptomatic orthostatic hypotension and some other agents. I have yet to be able to convince an internist to actually prescribe that for somebody. And I can tell you, I'm not going to do it for fear that I'm actually going to hurt the person's general health when I have an IOP zone in which I can help them. So it's a really wonderful subject matter for study, because there are half of people with open angle glaucoma have a normal eye pressure. Now, by no means do half of them have this situation of normal eye pressure glaucoma, and they're getting dramatically worse. In fact, the EMGT study showed that so-called low tension glaucoma is actually less aggressive than high tension glaucoma, which is exactly counter to what is in every textbook. So please stop reading textbooks.
All right, Adrian, did that give you some stuff to talk about here?
Yeah. So that's kind of what we were thinking on the same lines of was the thought of the concept of ocular perfusion pressure fluctuation, or the nocturnal blood pressure dip. So we know that with nocturnal changes, our systemic blood pressure does drop. patients that lay down have a little bit of a higher intraocular pressure. This is just a graph of nocturnal intraocular pressure at night. So we know that the ciliary body does decrease aqueous production, but that is often overcome by the fact that there's a decrease in conventional outflow through the trabecular meshwork, and also a decrease in the unconventional pathway through the uveoscleral pathway. And so we have this IOP rise at night of the optic nerve, and specifically at the optic disc. The optic nerve is supplied almost exclusively by the short posterior ciliary arteries, and its blood flow through the short posterior ciliary. We know that people with lower blood pressure will also have lower mean arterial blood pressure, and you see the concept of non-dippers, dippers, and over-dippers are from our internal medicine colleagues, and the non-dippers being less than 10% drop in blood pressure between comparing nocturnal to daytime, and dippers being between 10 to 20%, and over dippers between greater than 20%. So you see that during our hours of sleep, we have a drop in our blood pressure, which also results in a decreased mean arterial blood pressure. And that's going to be, that mean arterial blood pressure is going to be the pressure that's perfusing those short posterior ciliary arteries. So the concept of ocular perfusion pressure essentially is the amount of blood that's getting to supply that optic nerve. And that's going to be the difference between the mean arterial pressure, so the blood flowing towards those short posterior ciliary arteries, and that has to overcome the intraocular pressure. And at night, all of these things are kind of exaggerated. So our mean arterial pressure, is lower, but our intraocular pressure is also higher, which results in a lower ocular perfusion pressure. And some of the studies have shown that. So this is from Lee et al. In the AJO. Patients with greater than 20% drop in their nocturnal systemic blood pressure, so these would be over dippers, was a significant predictor for subsequent visual field progression, and that was because there was lower mean arterial pressure at night, and also a larger fluctuation in ocular perfusion pressure. Also, a study by Charlson et al. Kind of put a number to that. So the duration and magnitude of mean arterial pressure dips more than 10 millimeters of mercury predicted worsening of visual fields. So kind of after all that, it was similar to what had been discussed, but we sent a letter to the nephrologist and the cardiologist outlining the severe decline in blindness and the severe decline in vision and the risk of possible blindness. And also to mention the fact that they might have these dips in their blood pressure at night might be contributing to this. And we request 24-hour blood pressure monitoring.
Adrian, before you go there, I just wanted to just raise something
so that
on YouTube.
When that was done,
on YouTube, sorry to interrupt, on the YouTube channel, there's been some discussion here about the role of evaluation for sleep apnea. And I wonder whether we can get the panelists to just give their comments in this case specifically, and also in general. Should we be thinking about it? When, who, how? Does it make a difference? How does it change your treatment? And do you actually prescribe this, and the downsides of it? I wonder if we can just pause for a second and get that discussion. Maybe, I think Harry looks like he unmuted his mic, so he's ready to go.
Yeah, this is something that is well associated with open angle glaucoma. So we have a consensus of information from meta-analysis that sleep apnea, which is essentially, anoxia of the brain, so it's anoxia of the optic nerve, is something that could be associated. When you want to find out about this, don't ask the patient if they have sleep apnea. Turn around and ask the spouse, because they're the one who's listening to the snoring. And you'll never see a happier wife than the day you tell the guy he's got to go get tested for sleep apnea. So that is definitely something to do, and it would be something worthwhile to do with this particular patient, in my opinion.
And do you feel that would change the course of his glaucoma if indeed if he was found to have severe OSA and it was treated with? Could that potentially change the course of his progression? Do we know that, or is it? I mean, the association is there, but
no. No, and what you have is an association. So it could very well be not the sleep apnea at all, but something else. It could be the obesity. It could be something else. And until you actually do a randomized trial of treating sleep apnea versus not treating sleep apnea, you're not going to know. But since sleep apnea is a real risk factor for systemic abnormal health, you're not hurting the patient by making him wear a mask.
And I think that's the point as well, is actually, I think that you are potentially saving their life. Just a question for the other panelists. I mean, when we do treat with sleep apnea and the apparatus and positive pressure, what does that do to the venous pressure? Could there be there's been some discussion about that potentially increasing IOP with the treatments that we give classically for sleep apnea. Any thoughts on that? Do people need to be concerned about treating sleep apnea and potentially raising IOP in terms of raising venous tension?
I think whether it's a factor or not, I think the benefits potentially systemically of treating the sleep apnea probably outweigh that possibility. And if we don't know that it's definitely a major risk factor from the standpoint of the actual treatment being a risk factor from the standpoint of the glaucoma, the benefits are well documented. So, I wouldn't let that limit me or prevent me from, recommending treatment or agreeing with the treatment for someone's sleep apnea.
Be a nice study, a nice resident or fellow project that would have people bring their sleep apnea device in and measure what their pressure is when they're vertical and when they're horizontal, wearing it and not wearing it, and seeing if there are acute changes. I think if the thing is raising venous pressure, it's probably not raising it terribly much, although you really don't know.
Yeah. Okay. Interesting thoughts. Sorry, Adrian. I just wanted to raise some points that were raised on the chat group here.
Yeah, absolutely. Well, that was a good discussion. So in our patient, the average nocturnal mean arterial blood pressure was 20.3% lower than their daytime mean arterial pressure. And every nocturnal reading that they had was 10% lower than their daytime. Actually, 5 out of 8 of these readings were greater than 20% lower than his daytime readings. But despite all that, the patient—
What was the control group? Now, if you measure 100 people, how many people go down that way who don't have any disease or glaucoma? Is that a very significant number? I don't know, I'm asking.
I think there's actually, I think after there's a couple of studies as well that just sort of looking at some of the numbers of with respect to the percent drop and what the significance is. So we can get those references up after. I think, Adrian, you have those later on. We'll definitely get back to that.
It's a good question. I mean, when we think about like what is abnormal or what is concerning in the context of glaucoma, are we looking at an absolute number? Like, for example, in Baltimore eye study, I believe, Harry, was like the diastolic ocular perfusion pressure below 55, I think it was. There was an increase in the risk of incidence of glaucoma, if I recall correctly. Or are we looking at a percent difference from daytime? I mean, this introduces, again, like, I mean, we talk in generalities. Most of the population-based studies I've seen talk about an absolute number, like a cutoff, and talk about, the relative risk of incident or progressive glaucoma based on that cutoff, as opposed to looking at the difference between nighttime and daytime. I'm sorry to raise this, but what is the right way to look at perfusion pressure like this?
I think we've learned our lesson playing with magic numbers, haven't we?
That's my question.
We heard the magic number 21 again today at the start of this presentation. And the intraocular pressure is a continuous variable. There is no cutoff at 21. That's a meaningless thing to do, and it's really dangerous. So we ought to stop doing it. Likewise with this, it was an exponential change in terms of the difference between the mean or diastolic arterial pressure and the intraocular pressure in the Baltimore Eye Survey. It was an exponential rise in the prevalence of glaucoma in a daytime measurement of blood pressure and eye pressure. So we didn't have any data on nocturnal. And from the first paper on nocturnal blood pressure that Sohan Hayre wrote until relatively recently, we've had a real dearth of knowing what do the average 75-year-olds do with their blood pressure at night. Because if this was really dangerous in all humans, then we'd all be blind.
Well, yeah, and it's normal to have a nocturnal dip. It's physiologic, and that's my question. In that
Right.
we talk about doing it, we talk about it being a risk factor for prevalence and in some cases progression. But what do we do with those values, and how do we incorporate that into changes? I think that's, I think that's still some uncertainty in terms of practical application.
I think one of the things and one of our sort of thoughts in this situation, and in particular, here is working in conjunction, with the internist, and we have things that we can do on our end from the standpoint of surgery. And for this particular patient, from the very get-go, the discussion was that this will likely require surgery. We're going to look at everything else and see what we can do with respect to medications and so on, but start preparing the patient for surgery. And then I think, although we don't know exactly what the cutoff is and so on, I think the mindset, at least in this particular situation, was that if there was something that could be done on this end in a safe fashion, where everyone can be happy, in particular the internist and so on, with respect to their targets, then maybe we can consider that as an option. But, of course, it wasn't something that we were going to play around with on our own.
So due to our concerns and the patient's concerns, the internist switched his blood pressure medications from irbesartan and hydrochlorothiazide to losartan and a lower dose of hydrochlorothiazide, and for the patient to take it in the morning. So actually kind of after that point, we kind of reset the graph here, and we saw that there was actually a stabilization of their visual field index in the right eye. And that was after the blood pressure had stabilized and the meds had been changed. And in the left eye, we also saw a similar stabilization.
Well, I also love the fact that you up the frequency of visual field testing. I think something that you absolutely should do, no matter what else you do therapeutically, is in the patient who appears to be getting rapidly worse, increase the number of tests that you're doing so that you can be certain that is this person continuing to get catastrophically worse, or actually was it some kind of an artifact and they really aren't getting worse?
I'm wondering, Adrian, did you also do a post change Holter as well, 24-hour BP as well?
Yeah, so we attempted to order it, but the patient is quite busy and hasn't been able to come in to do it.
Yeah,
he's on quarantine. That's why he's on quarantine.
Yeah, it's been a little bit of a challenge. I don't think our patient enjoyed the first experience very much, and so has been a little bit reluctant to go back after, especially after being told that his visual fields had sort of stabilized a bit. I think the incentive may be decreased a bit, but it's still something that hopefully will happen soon.
Well, one of the chat questions has, with the episcleral venous pressure being 7 to 8, what would the target pressure be for a patient like this? And it's interesting that we have terrible ways of measuring episcleral venous pressure. We know it's greater than 0, but we don't actually know well what it is. The episcleral venometer device is pretty inaccurate. But assume that it is 7 or 8. Could you really get it below 7 or 8 with medical therapy? And I've never seen that done, accounting for central corneal thickness. So I don't think the only way you can get there to a pressure lower than that would be trabeculectomy. And I have tons and tons of people with pressures between 3 and 5 after trabeculectomy. But then their episcleral venous pressure becomes irrelevant because you're shunting through a hole and the fluid's coming through the conjunctiva into the tears. So episcleral venous pressure is no longer important. That the aqueous that comes through a trab or a tube ultimately gets back into blood vessels, probably, but not immediately in terms of the resistance circuit that's there.
So this was just one of the first studies that studied the mean ocular perfusion pressure. And this is just to reiterate that even in this study, they used a cutoff of 10% for blood pressure dip. So a difference in 10% between nocturnal and daytime. And this showed that there was a large fluctuation in mean ocular perfusion pressure. And this was related to changes, glaucoma progression. And again, to reemphasize that with our internal medicine colleagues, sometimes they might not notice or want or be willing to change medications until it reaches this kind of greater than 20% difference between the blood pressure in the day and the nighttime. So kind of in summary, the nocturnal dipping of blood pressure is normal and physiologic. In fact, patients that don't have a physiologic dip in their blood pressure are actually more prone to stroke and other cardiovascular events. But it's just important to remember that the definition of extreme can be different between us and our internal medicine colleagues, and it's important to communicate with our patients' internists if we suspect that low ocular perfusion pressure is a factor in the progression of our patient's glaucoma.
Well, thanks, Adrian. I want to just open up to the panel. I mean, I think you've really presented a case that opens up a lot of questions, which is great, and a lot of discussion, looking at glaucoma beyond the eye, talking about other systemic factors and IOP fluctuation, blood pressure fluctuation, sleep apnea, and how do you look at perfusion. It's interesting this patient didn't require trabeculectomy, at least not in the follow-up here, and you were able to stabilize their visual field. These are kind of cases that kind of remind us that we think broadly. Of course, there may be other confounding factors. Perhaps your concern made him worry more and made him be more compliant. That could be one of the things that could be going on, or something else, and you're changing therapy. So we probably don't truly know, but it does raise the importance of awareness, as you kind of mentioned. Anybody want to add anything? Gary, did you want to add anything to this? And
I think one of the big points that in this case that I wanted to make was that all the discussions and any changes or whatever were very much in conjunction with the internist, and sort of let them make the call. I think that the risk of doing things like going ahead and trying to change blood pressure medications, I've heard of in the past people recommending patients eat salt before they go to bed and so on. I mean, the risks of running into systemic problems, even death, stroke, whatever it might be, are significant and concerning. And I think this case was sort of atypical in many ways, but like you said, it sort of opens up questions and discussion about different mechanisms of glaucomatous change and so on. But it's not the typical case. So I think that really one of the big sort of points is that these sort of changes need to be made or in conjunction or with discussion with an internist, I think, as opposed to trying to make any of these changes yourself.
Fair point. Zainab, what are your thoughts?
Can I jump in? Actually, there's a lot to discuss, a lot of important points, but we don't have that much time, I guess. One point I would like to emphasize is there is a significant asymmetrical visual field progression. I was wondering your comments on that point. And another question is, would you want to see the baseline cranial imaging in patients with normal tension glaucoma? I was wondering your comments on that issues.
So comments from Zainab's questions.
Yes. Yes, please. Then.
Well, is glaucoma a symmetrical disease or an asymmetrical disease? Open angle glaucoma.
Having trained with you, I know the answer to that question. So majority of it is asymmetrical in nature.
Yeah, the worse eye is 50% more injured than the better eye across large amounts of population-based data. And since it's a genetic disease, that means it isn't a simple genetic disease, and it may be lots of things. Environmentally influenced, it might be the side you sleep on. That's one speculation. As a tiny factor in what's going on, it can be local genetic expression of proteins and other molecules. It can be wear and tear on one eye and the other that's asymmetric. But it is more common for glaucoma patients to have one bad damaged eye and one mildly damaged eye than it is for the two of them to go downhill together. Fortunately, because a lot of our functional influence of glaucoma is the better eye determines how well you're doing from a functional quality of life standpoint. So having one better eye is worthwhile.
In the average human, is there a difference in perfusion between the eyes, considering the bifurcations from the heart and the left and the right carotids?
We don't have good ways of measuring ocular perfusion. That's one of the, OCTA came along and everybody said, oh, great, now we'll be able to measure blood flow in the eye. OCTA doesn't measure blood flow in the eye. It measures the number of capillaries in which you can detect that there's red cells moving. That's what OCTA does. And it does it beautifully in terms of showing you some very pretty pictures, but it hasn't anything to do with blood flow. And we do have some ways of measuring retinal arterial blood flow. There's a huge literature by Juan Grunwald and his colleagues at Penn that did this over the years. I don't remember that they ever looked at right eye versus left eye, though. That's a great question. And there are people around, Richard Stone and others at Penn, who probably could tell you that they have that data and could get it out there.
Well, it reminds me of a patient that I had seen a few years ago that had, carotid artery disease and has much different carotid disease in one side than the other. And it was just coincidental, but the eye that the side that had the worst carotid disease had significant more cupping. Of course, it's an N of 1. The other eye was pretty normal, but it does raise the question. I think some data I did see that there is some differences in perfusion between right and left side coming off the heart and the bifurcations from there, so from the aorta. But who knows?
Yeah, I'm thinking of a medical school professor that we saw here once who came in. His usual eye pressures were 32, and he refused any therapy for 20 years and did just fine. One day he came in with a pressure of 15 in one eye and 32 in the other eye. And we said, that's really unusual. I think maybe you ought to talk to your medical doc and see. And before he got to the medical doc, he had the stroke relating to the carotid obstruction on that side. So while the perfusion fell, so did the eye pressure because it wasn't driving aqueous production on the ciliary body on that side. So I think there are some interesting crisscrosses going on.
Sure, ischemia or something. Yeah, interesting.
And if you want a real mess, throw in the intracranial pressure from the sitting up to the lying down position and how it changes translaminar pressure gradient, which I think is fun.
Yeah, and some people actually did
that one into the
CSF pressure, which is the other aspect to look at, which we didn't talk about much here, but I'm glad you mentioned it, Harry. Well, I mean that was great. Sorry, was there something else?
Sorry.
Zainab.
MRI.
Is there a role for the MRI in these cases? Is that your question?
Yeah. Do you want to see baseline MRI in all patients?
Why would you do that?
Yeah, as far as we know, some patients with neurological disease, some pathologies and chiasm, or some patients with neurodegeneration, sometimes they might be presented as high cup to disc ratio. That's why I'm asking this question. And I was wondering what you think about it. I don't do that in each patient. But I have some colleagues doing that. So that's why.
Yeah, tell them not to.
I'm asking
tell them to stop doing that. There are several good reasons.
Okay.
Dave Greenfield looked at a crowd of people with so-called low tension glaucoma, and they did MRIs on all of them and didn't find anything. And of course they didn't find anything because they didn't have neurological disease. If you have chiasmal disease, you have a different field effect. You have a different nerve fiber they're finding. You have loss of color vision. You have lots of other things. So if you have a glaucoma-like patient who has central vision loss out of proportion to the field, or color vision loss when they never should at that stage of glaucoma have lost color, absolutely, then you want to look for neurological disease. But that's this tiny proportion of all those people with open-angle glaucoma. And what we would do if we did MRIs on all those people, first is to waste a huge amount of money. And the second, if you say to a patient, you might have a brain tumor, let's get an MRI. You just permanently ruin the quality of life of a human being who will never in their life ever not think that maybe I still have a brain tumor, maybe they missed it. So I think there's a really good reason for good physicians not to order MRIs unless there's a potential neurological disease.
I think it's a great thought to think about, and we've all seen, glaucoma misdiagnosed and rapid progressors that end up having neurological issues. But as Harry said, there's something usually there that you pick up whether it's the rapidity or whether it's the pattern of the defect or whether there's other, visual issues that are neurodeficits. Certainly there's been case reports, though. We know there's been case reports of what looks like to be basically classic glaucoma. I mean, I published with Graham Trope back when I was a resident, a number of cases. But I mean, I think that that doesn't necessarily warrant, I think, routine MRIs for otherwise what looks like normal glaucoma. And I agree. I don't certainly do that. I don't do a vasculitis workup either. Although sometimes you see that, present in nutritional deficiencies that can present similarly. But I think it's great to have a differential, and that's probably where our clinical skills are going to be required. But thanks for bringing that up, Zainab. I think it's a worthy topic to discuss because there are still centers that do them fairly routinely. I know that.
Thank you.
Fantastic. Well, that was fantastic. That was a great discussion. Adrian, you did a great job in terms of provoking a discussion here and asking questions. So thank you. And Gary, thanks for supervising this case. I think it's a great real live example of the considerations, and you have some follow-up after a change in management. I think we have to give the internist credit, not you though, in terms of stabilizing this patient's glaucoma, perhaps. I'm just joking about that. Well, we're going to move along here because I know that we have a lot of things to discuss, and I wanted to just first of all share my screen. In these rounds, we do a variety of different topics. Sometimes we make them very academic. Sometimes they're more based toward surgeons. Sometimes they're more based toward residents. And we have had a lot of feedback that there's interest in just picking up techniques. So what I'm going to share, and I've asked my two fellows, Valentina and Tiziana, to also share their thoughts as well about suturing iris. Now, my objective is very simple. It's basically just to share some tips and tricks in terms of suturing your first iris. So think of that you're going to be managing one of these cases. These are my disclosures. There's probably not much relevant here other than maybe gore as a suture, perhaps, in some relative manner that I can think of. But I just want you to think that you're going to sit down in front of a case like this, and you have a patient who has an iris defect. And I will first say that the case that we want to think about suturing the iris for the first time will be a case probably like this, where there is a defect, a localized defect, and a defect that we believe can be closed, meaning less than 3 o'clock hours with sutures. And this would probably be one that we would consider doing. It would be difficult to do a more complex repair if the iris was very atrophic or fibrotic. The only caveat in this case is it's a light-colored iris, which is less forgiving when it comes to suture passage in terms of buttonholing. So the only thing I would add would maybe be a brown iris that would perhaps be more advisable in terms of patient selection. As always, of course, preparation is key. And I will always, either on my iPad or in my mind, think about where will I be placing my incisions? Where will I be using maybe any hooks or devices? Where might I be maybe using prosthesis? It's a real preparatory exercise in thinking about where I'm going to be placing my hands. And that's really important, I think, in managing it. I've often had to go around and do live surgery, and I pack a whole suitcase of sutures and micro instruments and everything I need to do because I know that preparation and having the right equipment is critical. I think during this time when many of us are sitting on our hands, yes, we have to do glaucoma surgery, but by and large, iris repairs and IOL repairs and things like that are not urgent. I think this is a good opportunity for those of you to consider using artificial eyes or cadaveric eyes. And the Simuli is one example where it's been designed, this particular model has been designed to help surgeons learn how to do iris suturing, watching some videos and then using the model, which is fixated very nicely to be stable, to be able to make incisions and clasp sutures and everything else. So I highly recommend it. Stuart, I asked Stuart if they're sold out. I don't think they're sold out, but on his website it says they're sold out. So I think it's debatable what suture is the preferred suture to use for iris suturing. And I will say that I've tried many different suture materials and different needles. I have settled on using tenoproline. I like the CIF4 curved needle. It allows me to work from a higher limbal incision, getting down to the iris and coming back out through a higher limbal incision. And this quarter radius curvature, I think, is handy for that. Also, the taper cut needle, I think, is preferred compared to a spatula needle to reduce the risk of buttonholing. We like spatula needles, of course, for corneal and sclerosuturing in terms of rotating knots and gliding through tissue. But in the iris, I would recommend something like this, which is more, I think, amenable for iris suturing. A taper cut like this works well. Perhaps one of the bigger points to consider is how will we suture the iris? after passing the suture needles. And there are a variety of ways, and I'm going to recommend that you learn at least a couple of different ways, because depending on where the suture is, where you're positioning, what the orbital exposure is and the ocular exposure is, will guide you in terms of what technique to use. We should all know how to do the Malcolm McCannell inspired suturing, and we have modified it and changed it. And Steve Siepser and Greg Ogawa, we owe credit for in terms of providing some nice innovations. I think at the very least, you can do this without sophisticated equipment, except I think it does help to have some hooks in some ways. Sinskey hooks, Kuglen hooks, ganchos, as my Spanish friends call them, I think are helpful to help manipulate tissue and to extract suture material. I have these schematics. These are old pictures actually, but these are schematics just to show you some examples. And what I want to show here, for example, is I want to show the positioning of the incisions, which is something that I think most surgeons pay the least attention to. The incision placement is critical to allow for a proper trajectory approach to suture pass the needle through the iris of the intended target, and placing them at least 2 clock hours away. If you can see my cursor here, is important. And I think this positioning here, if we're going to suture here, going at least 2 clock hours away on either side allow us to then create a nice path for the suture needle to pass like this. Making it too close will of course make it difficult to take advantage of this quarter arc radius, and making them too far away will cause more tension on the iris and potentially cause buttonholing. So just do consider where to make the incision. I'm sorry to belabor such a simple point, but repeatedly I see this as a mistake being made. When we talk about tying sutures, I'd like to classify them between the distal strand and the proximal strand. This is in relation to you as the surgeon sitting down. And I pretty well do 99% of my surgeries temporal. The only exception is trabeculectomy, but I generally sit temporally. So these are all reference to temporal incisions. Notice the distal strand in yellow and the proximal strand in red as we pass the needle through the incision, through the anterior iris surface, through the posterior pigment epithelium, and again, under, in this case, a haptic, this is a sutured IOL, coming out through the iris, and then in the anterior chamber, coming out through the incision. In a standard mechanical suture, what we basically do is we make an incision just over where the knot will be tied. This can typically be a 2 millimeter incision, maybe your main incision. Of course, you need to make it in the area where the knot is. If I make my incision away from this position, it'll be difficult. For example, if I make an incision over here, I have to draw the strands way out on this incision, and it puts lots of tension on the area. So make the incision, if you're doing a mechanical incision, typically in the area of where the suture knot will be tied. Once we do this, we extract both of these strands, the distal and the proximal strand. We bring them out. We have to cut the needle. We bring them out of the eye, and now you have basically 2 strands. Let me just show a video here. And again, I know on Zoom videos don't play that well, but I hope you can see needle being passed from right to left. There's the incision being made. These are typically easiest when you're working temporally for a temporal incision, if you're doing a temporal suturing. A Kuglen hook is used to withdraw both ends. So now we have 2 suture ends outside the eye through the main incision in this case. Separate them out. You got one in your right hand, one in your left hand, and you have 2 tying forceps. It's helpful to cut the suture down a little bit so they're not like spaghetti. Simply do a triple throw, grab the small end, short end, and then basically tie the knot and watch the suture come to the incision. In this case, the iris is coming to the incision, and that's basically what's cinching the knot down. And then we do a locking throw. Now, there are some that advocate, what's called the 4th throw pupilloplasty, and that can be used as well. I personally like to lock my knots, but one can simply do a quadruple throw, and hopefully it stays, and often it does. Now, that's the mechanical. Now, the Siepser sliding knot, originally described many years ago by Steve Siepser, as you see, looks very complicated. The advantage here is basically it uses a sliding knot to pass through the anterior chamber to the location of where the knot will be tied. And this can be advantageous to avoid traction on the iris that the mechanical does. The problem with mechanical is easy, but it puts traction on the iris and the knot, and it may cause iris trauma or buttonholing. And we really want to avoid these things, especially when the iris itself is not of great consistency. What we've done is basically modified this, and what I'm showing you again is the same example using a distal strand and a proximal strand. In this case, we're going to point to the proximal incision. So take note of the proximal incision, which is here, okay? What we're going to do is basically use the Kuglen hook. Again, if you speak Spanish, it's called gancho. And this is our Kuglen hook. We're going to go across the anterior chamber. We're going to grab the distal strand and bring it out through the proximal incision. So we will have no suture out of the eye here. It'll be sorry, a loop is brought out, and we still leave a strand out here. We still leave a strand out of the eye, which is important to keep, and I'll show you why shortly. So that's basically mechanical. Let me just show you in schematics here. I'm having fun doodling on Zoom. There you see the Kudlin hook bringing the distal strand loop outside the eye like this. Be sure that we make sure that we keep this portion of the distal strand out of the eye. You're going to need this to pull and slide the knot. But that's why we want to have it long. But keep in mind, look at what we've done with this distal loop. It's now out of the eye. So we have a loop of suture here, and we have a single strand of suture, which is the proximal strand. And I know it's probably getting confusing already with all the different considerations and different nomenclature here. Let me clear the screen a bit here. Now, once we have the loop out of the eye, we will then be ready to tie the suture. Separate them out. Keep the short end short. If this is too long, it becomes looped and potentially creates a loop in the knot. So keep it short. About 1 cornal diameter is all you need for the short end. This applies for any suturing, including conjunctival suturing. One end of the suture should be short and only needs to be about 1 inch or so in length. We have the distal strand loop, which is still here. So remember those positions and the names we're calling them. We now then use a tying forceps to basically loop around the tying forceps with the distal loop, which is in yellow. So loop around with the distal loop with the curved tire, and use the curved tire to grab the proximal strand like this. And then we pull the proximal strand through it. We've created this triple knot around it, and now to allow us to slide the knot in, we're going to pull this side here, and basically it'll allow us to pull the loop through into the eye like this, in this manner, while holding the suture, the proximal strand here that we've grabbed with the forceps. And again, it does help you to kind of go through a video. Many years ago, actually, Sebastian made a little cardboard cutout that was handy to use as well. But here you see we're pulling the strand through, and now we have a knot created. And that basically is a suture sliding knot. To lock the knot, we will then do the same approach here again and do a single loop here and grab the proximal strand with the distal loop as I showed here. So let me just show the video here. And again, this is on our YouTube channel that you're welcome to look at. But here you see we're basically passing the second suture needle, closing this iris defect. And let me just get to the position here. So you see, look at the incisions that we made. The incisions you can see are placed at least 2 clock hours away from the suture site. Allows us to take advantage of this needle and the long curved nature of it. We will then pull it out of the eye, and now you see we're taking a Kudlin hook and grabbing the distal strand here and pulling out of the incision, making sure we still have the distal strand out of the eye nasally. So make sure we still have this end still out of the eye so we can pull it through. There you go. Now you see the loop of suture here, which is the distal loop. And we have the proximal strand here. 1, 2, 3. 1 and 2 are distal strand loop, and 3 is the proximal strand. Make sure the loop is not twisted here. So that's why you see number 1 strand goes all the way out of the eye through the nasal incision. Number 2 is coming from the nasal side of the iris. And number 3 is coming out to the temporal side of the iris, which is the proximal strand. Keep a distal orientation. Avoid the loop from being twisted. It may prevent you from cinching down that knot and locking the knot. So keep that in order, 1, 2, 3. And remember, of course, we still have suture here that's present here distally out of the eye here. Okay. And here, this is basically what we're showing here, out of the eye like this, and coming out like this. So that's basically the suture as we're looking at it here. So keep that orientation. It's important to keep that orientation there. And I know I'm probably losing a few people here, but hopefully this will give you enough to kind of think about it before getting in. And watch the video again. The videos help to replay it. So watch what we've done here. We basically are cutting the proximal strand, which is basically just a short end here. And we're going to take the distal loop. We're going to use our tying forceps to basically loop around the tying forceps, around one arm of the tying forceps. And again, I'm sorry, I'm sure the video is a bit jittery for you. We'll loop around the forceps here. So we have a loop, and we now grab the proximal strand. Now we pull the distal strand, and we slide the loop along the proximal strand so it reaches the iris. And that basically is how we do a triple throw. And to lock it, we'll take the Kuglen hook again and bring out the distal loop. Don't take the whole suture out again, but leave a distal strand present outside the eye nasally. And we now have the distal loop present on the conjunctiva. We will then do a locking knot, which is basically going to be, as I call it, backhanded turn of the curved tire, as you watch here. Stay inside the loop, loop around that tying forceps and grab the proximal strand, and then pull the distal strand to slide it in. And that basically is the Siepser sliding knot. And you can see how elegant it is. There's very little traction on the iris compared to the mechanical suture. One last suture I'm just going to show you, basically using micro instrumentation. And these are using micro tying forceps or micro graspers to hold the iris, as you see here, which I think do elevate the ability to control the procedure. And what I'm going to show you is what we've described as I think Sebastian was the first one to label it McAhmed, because it's a mechanical suture, but with a little twist that we came up with. And we're using a Kuglen hook again to bring out. In this case, we're going to bring the suture all the way out of the eye, all the way out. We don't leave a distal strand. Remember in the Siepser knot, we leave a strand here. In this case, we do not leave a strand. We bring it all out of the eye through any incision you want. Use a micro tying forceps to basically tie the suture, looping around the long end, grabbing the short end. And then in this case, we use the same micro tire to push it into the eye. As you can see here, to me, this is a little less complicated than the Siepser sliding knot, but it still has more control than the mechanical. We slide it in the eye, we cinch it down, and we're done. It's a very simple idea, actually, and I think having the right instruments help. This is just showing a view of surgery, doing a pupilloplasty, but I don't want you to look at the actual microscope. I want you to look at the hand positions, because I want to emphasize the importance of positioning our hands. And we're holding instruments fairly flat. The grip of our instrumentation will vary depending on the action and the incision, and also the periorbital anatomy. And as you see here, I basically use a micro forceps to grab the iris and pull the needle out with my needle driver. You see I'm using a Kuglen hook. Notice how flat I'm holding the Kuglen hook on its side. There's a tendency for surgeons to forget the concept of a fulcrum. And when we're suturing in the eye or when we're suturing around the eye, we have to be very mindful that our incision should not be twisted and turned. We should be observing the principle of fulcrum and pivoting in the incision. And you can see I have a micro tire in my right hand, grabbing the short end of the suture, which we placed on the cornea. Remember, we brought out both ends out of the eye. We will then grab that suture and push it into the eye. As we do this, notice how flat the right hand is. And this allows us to work through the temporal incision without moving the eye, without opening up the incision, without burping the eye. That's my fellow telling me what to do. And you can see how basically we are holding our position. So let me just quickly show you a case here of this actual technique. Now here we're showing the incisions. Notice again how we placed our incisions in blue here in line with the needle that we're going to be using to suture the iris. And we'll basically show the suture pass. This is a patient of trabeculectomy many years ago, and it's had an atonic pupil since then with disabling glare. And again, look at the micro forceps, how useful it is to grab the iris. So now we have passed the needle all the way through the eye. It helps to have a cannula to come out of the eye to avoid grabbing the knot. What we have now basically here is we have, again, in red, the proximal strand, and in yellow, the distal strand, and in blue basically is the suture that's bridging the iris defect. What we'll do is take a Kuglen hook and grab the distal strand and bring it out of the eye completely out of the eye, unlike with Siepser. And what we have here now basically is the distal strand out of the eye with the proximal strand. We'll cut the distal strand typically down to about 1 corneal diameter in length, right? About 12 millimeters or so. And then we will do our suturing. use a micro tire to basically grab the short end after looping it, cross over to flatten the knot, and then push the knot into the eye with the micro tire. It's very simple to do, in my opinion, and it's probably the easiest technique to learn, in my opinion, because it really doesn't involve extra gymnastics with a slipster knot, and it keeps things organized. And we can lock the knot here, as you see, by bringing the suture back out of the eye, doing a locking throw, and then bringing it back into the eye by pushing it in, or using another incision. So that basically is essentially the different approaches that we can use to suture. And I want to just actually pause here, and I'm going to actually ask Tiziana for her thoughts, because Tiziana is actually doing exactly what we're trying to teach, which is basically learning these techniques, and I think she'll have a good approach in terms of pros she's learned in learning these techniques. So, Tiziana, I'll hand it off to you.
Yeah. Okay. So, can you see my screen? Are you able to see my screen? Okay. So, this is how we feel when we are doing our first iris suture with Ike. Yeah. We get nervous. It's a different kind of surgery compared to what we're used to do. And I've just shared some iris suture tips that look silly, but in my case, it helps me a lot. And the first tips is that you have to plan your suture before you start doing the iris sutures. So you can grab 2 micro instruments and put it all the 2 ends of the iris defect together and already plan how you're gonna suture this defect. The second tip is to plan your incision. As Ike was saying, when we place the first incision, and then we have to kind of see exactly where the tip of our needle will go through, and then we have to know exactly where we need to put our incision. In this case, we use the cannula to know where the direction of our needle. The second tip is when you dog your needle with the cannula, don't let it go the needle when you're holding the needle with the needle driver. Don't let it go until you see the tip of the needle out of the eye. So other eyes, you can lose the needle inside the anterior chamber, and then you can have uncontrolled movement, and you can have bottom hold. Also, no flickering. When you have your needle through the iris tissue, your movement has to be very, very controlled. You cannot do any flickering, because otherwise you can also have a bottom hold. And when you're manipulating the suture, when you're pulling the suture, we have to be very careful, because if you do any more like a strong movement, you can have these, you will see here that because I was like pulling too strong here, I created an iatrogenic iris hole. So we also have to be careful when we're manipulating the suture. Other tip that I think is very, very useful, keep your sutures organized, because other eyes in the middle of the surgery, you will have like so much trouble. And it's one of the tips that Ike is always, you can see here that Ike is with the cannula, letting me know how to do it. But I think it's like a super, super important. Then it keeps your surgery, you're getting more efficient during your surgery. Also, other tip that is super important is don't lose your suture during surgery. So when you're pulling the distal part of the suture, hold the other part with any forceps, because otherwise when you're pulling the suture, you can just like lose your suture and just lose your job. We have a colleague that did a cerclage, and by the end of the surgery, when he was tying when he was doing a knot, when he was like pulling the suture to tie the suture, he just lost all his job. So this is a very important tip. And that's it.
I'd like to add, those are great points to see. A few things, like if this is your first time doing an iris repair, the patient definitely has to be pseudophakic. And even if you are doing cataract surgery and you see the iris defect, I think it would be wise to do the cataract surgery first, then wait a few months and then proceed with the defect. That way you can just stabilize the lens and it becomes fibrous, and then you just go ahead and proceed with the iris repair. Another thing is that you're going to be using that incision and you're going to be pivoting with the needle. So just make your incisions a little bit bigger, make your job easier. I know that I try to make them small and then I always run into trouble. So just feel free to make them a little bit bigger. That way you have more space to work. And I mentioned having the CIF4 needle. For that needle, you kind of have to use paracentesis ports to go through there. I know that with other needles, you can just go through the cornea, but you can't with this one because otherwise you're going to cause that corneal leakage.
Yeah, I have to say, I do like having a couple of paracentesis. I just find there's more versatility in doing maneuvers and things. I know some people can try to get through the eye, get to the cornea just directly. And the one thing I didn't mention was that I think what we forget talking about is actually the control of the needle. And if depending where you're grasping, I mean, if you grab too close to the tip, you can't pass it through the AC. You have to grab it pretty far down the the needle closer to the swedge to allow you to have a full excursion through the anterior chamber. But that does reduce the control of the tip of the needle. So be sure to have a good grasp. Grab it, a bit farther down the shaft a bit, or not the shaft, but of the needle holder itself. And if you're not certain of it, release and re-grab again. I think the needle control is really important. Great. So that was hopefully, just some tidbits and pearls. Again, I think watching videos really helps. And Vanessa just mentioned, yes, grab enough tissue. That's a really good point. I find sometimes, people grab a very tiny bit of tissue and it will cheese wire through it. So grab a good piece of it, and don't worry if it's a little bit raised after you tie the knot. That's okay. It'll have some give in it. I think it actually helps. Do you need to inject viscoelastic in the AC? Absolutely. I mean, we often replenish more viscoelastic in the eye, but be careful not to overfill the eye because then you're working very deep depending on the AC depth. So just put enough in to keep the chamber maintained. We typically use a cohesive agent or a super cohesive agent that works quite well. And I think there's some questions that came up as well about anesthesia. I think do what you're comfortable with. I think certainly when you're learning, I think a block is reasonable. Not because the patients have pain. I don't think they have too much pain actually, but if there's movement as the needle is in the AC, that could potentially make it difficult for you. We typically do them under topical, to be fair and honest, with some intracameral, but I think blocking is a good place to learn. I certainly would do that initially as well as you learn. So it is something I really believe that I think a comprehensive cataract surgeon, anti-segment surgeon can learn, and doing, again, the right patient with the right tools and understanding the physics of what we're doing inside the eye and outside the eye with hand positioning and keeping the sutures organized, I think are critical and important.
Yeah, I think the most challenge is the hand position for sure, because you have to work the whole surgery with your hand flat. And this is it's very different from when you're doing cataract surgery. So I think it's the biggest challenge.
One of the concerns by doing iris repairs is that the pupil can get peaked. So do you have any recommendations on how to prevent a peaked pupil after your pupilloplasty?
It's a good point. And this is so much part of the art of imagining where the iris should be positioned. And so it helps to have a couple of forceps in the anterior chamber and grab both sides of the iris and bring them together and kind of approximate where the iris will be and what it will look like. That's one tip that'll help. I think besides that, if you have missing iris, sometimes it's hard to avoid it. And we do use a technique that we use using cautery that we described many years ago, coincidentally, actually, where we use a cautery to do a bit of pupilloplasty to kind of reshape the iris to make it more round. And I really hate looking at a triangular pupil or an oblong pupil. It's not pleasing cosmetically. You can do that postoperatively as well, using an argon or using a diode photocoagulation laser as well. But I think those are things that help you to add improvement on the cosmesis side. So I'm gonna move forward here just to keep the conversation going, and I want to thank Sebastian for joining us. Thank you, Tiziana, and thank you, Valentina, for great pearls from your perspective. You guys have done great work so far, and hopefully once we're finished with, or at least we're back to work after COVID, the crisis will be back into the eye again for these cases. Sebastian, I'll give it over to you. Thank you.
All right. So here is a quick case that I wanted to present. Early on, Jim asked me if I had interesting cases, and this is one that came up. It's a subject I don't see a lot of people present, and there are only a few videos on YouTube that you can go through. So I thought this was interesting. So I don't have any financial disclosure that's relevant to this talk. And you've seen the situation evolving rapidly over the course of the last few weeks, but there's one thing that's new, and it's apparently growing quite fast. It's quite viral. It's actually the Prism Eye Round. So I want to thank Ike for putting this up, and I think it's a new way of bringing people together, and I think we're reaching quite a lot of people out there. So in the few last weeks, I think you did a great job creating this new platform for education. So congratulations. So the clinical case here, it's a trauma that I was referred. It's a 42-year-old patient that had a budging cord injury 2 months ago, basically, and is presenting visual acuity was 20/200, and had a quite low IOP, IOP of 3. So he was put on after the initial inflammatory period. He had a small hyphema apparently that resolved. We see a bit of blood on the anterior capsule of the crystalline lens. He was put on atropine once a day and Pred 40 4 times a day. And the slit lamp exam revealed like a quite deep anterior chamber, some trace of phacodenesis. And the posterior pole, you see a picture. It's not his actual picture, but we saw that he had maculopathy because of his low IOP, and the gonioscopy pictures that I was able to take showed here a little bit of iris root disinsertion, because you can see the ciliary body there, but quite a large ciliary body band, and probably a cleft, ciliary body cleft, cyclodialysis that extended quite extensively. For maybe from 11 to 3 o'clock hours. So it's quite a large cleft here that we have to deal with. And just as a reminder, what is this ciliary body cleft? It's the detachment of the uvea insertion at the scleral spur. So basically the longitudinal fibers of the ciliary body. And the problem with this is that it results in the direct communication of the space. So the anterior chamber has direct access to the suprachoroidal space that may result in the shunting of the aqueous humor there. And it may result in hypotony, which may be problematic. And actually, once the maculopathy settles in, it may lead to irreversible changes. So this is really a serious problem that we need to undertake. Other changes that we can see with this situation is a cataract development that may be a bit faster than what we usually see with age. We can see corneal changes, corneal edema, some kind of low-grade uveitis, choroidal effusions, and also optic nerve head edema. So in this, I don't know, Jeb, if you have the polling questions. So what would be your preferred approach here? Would you just observe and wait because cyclodialysis cleft may close spontaneously on their own? Would you do argon laser? Would you go transscleral approach, whether you have access to cryo or cyclodiode? Or would you go straight to surgery? Would you adopt a direct cyclopexy or indirect approach?
And Sebastian, how long has it been since the trauma?
So the trauma has been, it was 2 months ago, let's say.
2 months, okay. And the cleft looks about 3 o'clock hours or so, would you guess?
Yeah, 3 to 4 o'clock hours.
All right, so we got the poll here. Let me just share the results here. People are still voting, so we'll maybe let them vote a bit longer. But a lot of different options you have here, and I guess the related question to this, Sebastian, if there is surgery, would it be combined with the cataract surgery, considering there's a cataract and also is the iris dilated? A lot of questions to ask about that one as well. Let me share the results for you, Sebastian.
So 30% would. Does anyone see the results? Yes.
Yes,
I
think
to explain. Everybody sees it. So a third just decided to observe and wait. So I'd like to have my my panelists maybe comment on this. How long would they wait for?
So I think I can chime in a little bit. I mean, typically, if I see a ciliary body cleft, I'll wait up to 6 to 8 weeks. But if you said it's already been 2 months, you're probably already at that stage where things are probably not going to heal that much more or scar down. So it may need the assistance of surgically repairing it at this point. And then I don't know if you want us to talk about like manners in which or different types of techniques for repair, if you're going to touch upon it later, but
I'll go through that a bit.
Yeah.
So that's interesting. And is the presence of a maculopathy will trigger your decision towards more observation or a more surgical approach?
Oh no, yeah, it's not going to go away by itself. So the maculopathy is definitely if the vision was fine, there was probably be no reason to repair, even if the pressure was low. But if you start to get maculopathy, I think there's no doubt that you need to start to do something surgically to close it up, scar it up, and then hopefully flatten out that macula, which can take, I mean, I've had a case like this where it has taken, just a couple of weeks to flatten out. And I've had one where it took a full year and the pressure was at 20. Anytime it came below 20, it would start folding again, but a full year of being at a pressure of 20 and above, and then it flattened out. So just when you think you're about to give up on this maculopathy, there's still hope. It still flattens out. But certainly it pushes you to the edge of doing something surgically for this patient.
All right.
Yeah, Zainab, I'm just curious, Zainab, what you think about, this is always a debate we have, of course, whether it's a condition like this with the traumatic cleft or whether it's like post-bleb or surgery. And how long can we wait, presuming that there's maculopathy? And we've seen some cases reverse, of course, others don't. I mean, do you have a general idea about how long do you wait? And
of course, we can wait, but in this case, I would go for surgery because it's been already 2 months, and IOP is too low, and the most important thing is it's not that small. The cleft is almost 4 o'clock hours, So these are the major reasons for me to go for surgery. So I would go for surgical direct cycloplexy.
I'm just curious.
Lift partial scleral flap and then scleral incision, and then try to reoppose it.
Yeah, I'm surprised that there was not a lot of people who considered to maybe just try laser. I mean, I guess I always wonder, like, what's the downside, and maybe it'll stimulate some inflammation and it'll scar. I do agree it's a pretty big cleft for that, but what would be the harm in maybe just trying a good heavy laser maybe once or twice?
Yeah, probably. That was my next question actually. So if you recommend the argon laser, you mentioned that it's quite a big cleft. Would you? Is there a limit? Do you try argon laser on every cleft, or is there a cutoff? Do you do it on only 1 clock hour or less, or 2 clock hours? Is there? It would be interesting to see what would be the typical treatment plan for this kind of patient, because we know that with argon laser we can do 1 session, but if there's no signs of improvement, well, maybe we can skip to another step in the decision for surgery. But if we see small improvement after 1 treatment, maybe we can do a second or third even treatment with laser. So most, I think half of the respondent here, they said, well, if it's a small cleft, they would probably typically go with argon laser. But if it's even larger than this, they would probably consider other option. So do you? I'm going to ask Ike because he mentioned that he would try it. Did you try this on every cleft that you see, or?
I guess the downside of doing a laser, I mean, it can be uncomfortable, yes, and I actually typically don't even put them on steroids after the laser, and I'd like to get right deep into the cleft with the lens. I think the downside to me is not a lot to try it, and I've been surprised sometimes, even for 3-4 o'clock hours, where I can get a significant response and I can get the pressure back up again. I do agree, the bigger the cleft, the harder it is, and I don't only look at the size of the cleft. I look at the depth of the cleft, right? So, I mean, you could have a very shallow cleft and it's 3 o'clock hours. And I think that would, to me, be more amenable to laser versus a short cleft that is really deep, And I think that's one difference. Sometimes it is hard, though. I understand the eye is soft. The chamber is a bit shallow. The pupil's probably dilated because you put them on atropine. So I understand the challenge with that. What I do, my little trick is I will inject a little bit of viscoelastic in the AC and wait a little bit. Let the chamber deepen up a bit. I don't go right away and do laser, but I wait for it to kind of hydrolyze a little bit, liquefy. And then I have a little bit of tension in the eye to do it. Just be careful not to put too much viscoelastic in. Otherwise, it makes the clip larger and harder to get in there. But I think it'd probably be worth, for this one, I would certainly consider it as a first chance, but I would try usually twice. I would try twice, 2 lasers, and I do them like a couple weeks apart. And if it doesn't work, I tell the patient, listen, you're probably gonna have to do surgery, but this may avoid it. That's kind of been my approach.
Great, it's interesting. So yeah, so the different options that it's been described. First, we can always observe and put the patient on cyclopedia. I think it's a reasonable option to do argon laser because it may help or it may not help. I think the point that it's not the extension of the cleft that's relevant here, but the depth or the dimension, how deep you can see that. There's been some description of using a viscoelastic. Viscoelastic can help into making the diagnosis, but it could also help into treatment because you can partially rise the intraocular pressure with the OVD, and sometimes it may assist you into doing either the argon laser or other options. So the other option that are there that's been described is the translateral option. So you can use either cryo or diode. Here, do you have any comments on the typical setting you would use for such a treatment for a cleft?
I think somebody asked what kind of settings people use. I don't know if others want to answer that. What settings would you use for the treatment if you're doing photocoagulation?
So if you use a cryo, well, the first thing is to really document the extent of the cleft. And if you're not sure, you can use a UBM. As you see on the picture above, this is a UBM image showing the effusion in the cleft. You can help localize. So if you use cryo, there's been a double thaw technique or triple thaw technique that's been described. If you use a translateral diode laser, it's usually your typical setting. Now here, the goal of the treatment is not to create hypotony by destroying the cellular body, but just to create inflammation. So probably the low power setting with longer duration of treatment, probably around 3 to 4 seconds and 1,000 milliwatts would be probably sufficient. I don't know if the other agree on that, but that's what I've seen, and that's what I've been doing in my few cases over the few years.
Yeah, I have to say, I mean, I've only tried it once, and it didn't help in that one case. I always worry about the impact of cyclotherapy and what you're doing to the ciliary tissue itself when you're trying to treat hypotony. But as you know, there've been case reports. Yep. Just go back on the laser, by the way. As far as I typically use 532, I typically like to use a spot size so I can get the spot into the cleft of around 200-300 microns. I use a long duration of like 0.2 seconds. And I will titrate up my wattage. So I'll probably start around 300 milliwatts, and then I'll go up from there. I do want to get a pretty good reaction. I do want to get like some good tissue contraction and some bubble formation as a result of the laser. So it is going to be pretty strong laser. and I aim as deep as I can into the cleft, and I try to get right in there as far as hitting that thing. So that's kind of my settings for that. But as you said before, some people have done transscleral. I've tried it once. I don't know. To me, I just was a little bit shy just because of the concern of the impact of the ciliary tissue, which already I'm trying to treat hypotony for.
Exactly. So maybe if you have a small cleft, localized cleft, that's something you can do. But if you have a more extensive cleft, that maybe other option, surgical option would be better. So the surgery that are there, there's been various case reports and techniques that's been reported. You can always do a phaco with the intraocular lens implantation. You can use CTRs also. You can use endolaser, whether the retinal laser to directly do laser on the cleft or on the ciliary body. There's been a retina technique using a mix of cryotherapy and post-plantar There's been direct diathermy to the ciliary body. Anterior scleral buckles have been described also, and translimbal or transscleral suture of the ciliary body. One technique that's interesting, but I haven't tried it. It's a suturing a CTR in the sulcus, and or CTR, or you could use also a capsular tension segment. So just the segment in the localized cleft that could be described. And the other technique is the video I'm going to show is a direct cycloplexy. So I apologize for the quality of the video, and I know it's a Zoom, but you have the link on YouTube if you want to have a look at it. I didn't have recording facility at my hospital, so I basically hooked up my iPhone on the scope, and I was able to get this picture. So you see the little bit phacodenesis early on, and the phaco, well, I did a generous physical dissection to be able to implant the CTR. As you see here, you see the loose diffuse sonules that are there, but you see the passage of this, the capsule tension ring. So once the phaco is done and the intraocular lens has been implanted, I do a peritomy over the area of the extent of this ciliary body cleft that I've diagnosed prior. And here I'm going to outline a scleral flap. So as Zeynep mentioned, a partial thickness scleral flap over the 11 o'clock to 3 o'clock area. And the dimension of the flap is 3 millimeters from the surgical limbus. And once you've retracted this flap, I'm going to measure a millimeter to a millimeter and a half and do a full thickness scleral incision in order to go find the ciliary body that I'm going to have to suture. I do it in, let's say, 1 clock hour at a time, because I'm worried that the surgery is done under topical. So I add more tetracaine drops. So every time I expose the ciliary body, because the uveal tissue is quite sensitive. But you see here that you can pass a needle through the fine uveal tissue. And I do an X suture on over this 1 clock hour area using a tenoproline suture. So basically the same kind of suture that Ike mentioned early on, using for pupilloplasties. And once you grab the uveal tissue, I do a neck suture, and then I'm gonna travel along the whole course of the extent of the cleft. And I'm going to slowly extend my full thickness incision, and then grab more ciliary body tissue along the way. So this is a quite extensive surgery. You have to take your time, but you're going to see here where there's an area there's maybe uveal effusion. Here you see a bit of gush of fluid, or it may be the more direct communication of the cleft into the anterior chamber. And again, you grab the ciliary body tissue and pass along your sutures. I've seen other techniques that describe where they just do this full scleral incision. And I'm worried about maybe a suprachordal hemorrhage that could happen at any time. So I like to have the partial thickness flap over there. So if I have to close the eye in the rapid fashion, if anything goes sour, then I think it's going to be probably more stable. Also, the other advantage of having a partial thickness flap over the full thickness incision is that maybe in the long term, it may be more stable eye if the eye suffers another trauma. You probably could share all the story of an old intracap or extracap patient that had a trauma and the eye just opened up again with a minimal trauma. So here you see the full thickness incision has been fully closed now, and it's caught the cellular body. And now I'm just closing again the superficial scleral flap. Here the camera is a bit out of focus because a nurse just bumped onto my iPhone, but we're at the end there. So, and after that, it's just closing the peritomy.
I think, Sebastian, that's a great technique, and I think I totally agree with what you're saying. And I think a couple of things I want you to address, and maybe others can as well. When you have a 3 o'clock hour cleft, how wide do you make the incision? Do you go wider than the cleft to be sure? And number two, everybody always asks whenever we put these videos up, well, how come we're not seeing all this bleeding? I mean, somebody's body is vascular. Why are you not seeing bleeding? And so, what are your thoughts on that? And maybe what Zeynep and Sahar want to add to that as far as technique?
I think identification of the extent of the cleft is key here. I saw that patient quite often when he was first referred to me, so I knew exactly where the cleft was. I took the time to take the gonio pictures, and when you do the dissection, it's a bit hard to tell from the video. But when you do the full scleral thickness cut down, you see if the uvea or the cellular body is right against the scleral bed, or if there's a gap. So usually I will extend a bit, maybe 1 clock hour, half a clock hour away from what I'm expecting the cleft to be present at. The bleeding question, no, honestly, if it doesn't bleed unless you really damage it with your blade, I guess. If you go when you do your scleral incision, you do a small movement until you see the cellular body there. If you're afraid that your blade may hit it, you can visco dissect. So really push it back a bit further so that you can extend your full thickness incision, and then after that grab it with tissue. But the cellular body, yes, the uveal tissue is quite vascular, but the cellular body is a muscle, so the muscle has a consistency that you can grab tissue with, and surprisingly, yes, it doesn't bleed.
Yeah, I'm curious what you think, Sahar, about those points, or anything else about technique.
Yeah, so I think what's understated is if you have a subtle cleft, it's difficult to find that in the OR. So you can of course use a gonio prism in the OR, but my preference is to identify it before you take the patient to the OR. Just kind of mark it with a marker, actually right before, if you happen to have a slit lamp in the OR. And if you don't, then you can just use it during the time of surgery, because when you want to make your incision, you want to make sure you're at the right spot, because the cellular body is going to be there. It just happens, you want to make sure you're suturing the right area. Otherwise, you'll do all this work and then you'll go back and be like, oh, I missed half the cleft. So that's really important to identify its borders, and I think it's really key to do it a small amount at a time, as you mentioned, Sebastian. So those are some of the key points. And then I think that you pretty much hit a lot of the points that I would consider for this particular case.
I think what also helps is to put viscoelastic in the AC, hyperfill the AC, put a gonio lens on. I think a gonio lens intraoperative is a very good idea, because then you can actually see the extent of the cleft. And I actually overdo it. I kind of go at least a millimeter or two beyond that, because I think the worst thing is you close the cleft and there's a small portion still left. And I've seen that happen before. And so I think it's worthwhile to do that. And you're absolutely right, Sebastian. I mean, we think about suprachoroidal hemorrhage. It's because we have bridging vessels basically in the space that essentially get distracted and pulled and then shear and break and cause bleeding. This is a different story. We're passing suture needle through that ciliary muscle tissue, which I think is a different story than what we classically think about with a hemorrhage. So I think that's one reason why we still can get, there's still vasculature in the muscle, of course, but it's a different scenario than a typical bleed we see suprachoroidal hemorrhage.
So how about success rate? There's been a retrospective study which Ike's group was a part of, and Juan Mora also. So they compared their success rate. It's a multicentric, so surgery versus laser, and surgery has the advantage here. And we discussed this. I think the extent of a cleft is going to tell you more about what's going to be the outcome. And back in 1994, I think those group, Kuchler and Naumann, described that probably for just argon laser alone, more than 2 clock hour is probably too big of a cleft to expect that the laser alone will do it. So you have to consider really the surgical options here. And in Keith Barton's group of reoperation, actually of cerebelly cleft management, up to 50% of the patient needed more than one surgery, which is something that maybe you have to expect. And there wasn't a statistically significant tendency for cleft size to fail, but it was definitely a risk for failure if the larger the cleft, the larger it was. I'm going to show you another video. It's from YouTube. It's an excerpt of one of Keith Barton's group video, and I would encourage you to all go see it on YouTube. This is it's nice to see the actual cleft there. I don't know if this case is done under topical, but I would have probably would be a bit more stressed to do this kind of dissection. But it's nice to see the direct identification of the cleft and the reapposition of the tissue going translevel here with the nylon sutures. And the video on YouTube is really great to see. So I would encourage you to see is a technique here also. So in the post-op period, what we should expect is probably an IOP spike here, and it's been reported that probably the vast majority of patients will spike over 30 millimeters of mercury. Why is that? It's probably there's been a collapse of the natural outflow system. There may be a collapse of Schlemm's canal, or maybe the collectors, or maybe there's been some debris, some fibrotic response in there. So that's something that everyone that's going to be tackling those problems needs to expect. So for our patient, post-op day 1, his vision was improved. Of course, the cataract was removed. His IOP was 36, and the question I have for my panelists is, would you treat that pressure, or would you just watch it?
I would treat it.
You would treat it?
As you said, IOP spikes, post cleft repair IOP spike is not that uncommon. So in this case, IOP is pretty high, and I would treat it.
Would you? Well, first question: how would you treat it? And would you have concern that by putting the patient on aqueous suppressants, it might bring them back into hypotony and then reopen in a possible small cleft that would be still present?
If I'm sure that it's pretty well reposed and I'm pretty confident with my surgery, I can go ahead and start treatment.
But also treat, I think, with this and bleb revisions where you're closing the trab, in trabeculectomies, you're gonna most likely get a post-op spike. And the eye was so hypotenuse for so long, it was producing so much aqueous for so long, overcompensating, so to speak, that when you do close it, it's still producing that aqueous at that same rate. So you need to kind of catch up with that. You need to kind of slow it down, essentially, to some extent. I also think just use Diamox temporarily if the patient can tolerate it for a few days. because leaving them at 36 or 40 or 50, I mean, no doubt they're going to be throwing up in your clinic the next day. So you want to treat them for that. And then just observe, kind of closely, and then taper off the meds and see where you land.
I think the level of post-op IOP really is going to tell you if you need to treat or not. In my case, I decided not to treat at that level. The patient was young, his optic nerve was not suspicious of any sign of damage, glaucoma. I think for a few days I could watch it. As you mentioned, if they're more towards the 40, 50 of IOP, yes, I would probably use something like Diamox, but at that level of pressure, I'd just watch it and observe it. So I ordered him to come back the next day, and over the course of the next few days, he settled to around the low teens. So he had a nice evolution there. So we're open for our discussion here. A few references that are interesting, and definitely go see the YouTube videos if you want to see this again.
There's a question on here about if you want to do cataract surgery at the same time as doing a repair. I probably would not. If that cataract needs to be taken out, I would probably do a cataract and consider putting a CTR in and suturing that maybe. I don't know. What do you guys think? Anyone else on the panel?
In this case, I would take the lens out because I believe there's going to be a complicated cataract. So I would combine surgery with cataract surgery with phaco, and then probably put the CTR in the sulcus, maybe the sutured ones with two edged ones, in both sides. Yeah, I would do that.
Yeah, it's a good question. I mean, I think there probably could be either answer. I think you could often doing the cataract surgery alone, if it's small enough, you might be able to get some closure, and if you can put a CTR in and maybe suture, like you said, that might be helpful. I tend to kind of do it. I've done mine typically together. In fact, often you get a dilated pupil as well. So I'm really cavalier, and I'll do a cleft closure and I'll do a cerclage as well, and I'll try the detention back and forth. That's probably a bit much, but I do think that you're right. I mean, the more we add to it, the more potential there is that we lose the closure. So I think it's whether you do it now or later, though, it's going to be a question, I guess, if they need a cataract anyway. So that's what I would say. I would also add that sometimes we do these closures and the pressures still are low for a few weeks, but I wouldn't get overly worried yet, because sometimes you close the cleft, but there's still an effusion. So image these patients, and what I've done sometimes, I put viscoelastic in the AC to get the pressure up on purpose to basically tampen that and squeeze out any extra fluid. So it's unpredictable. I tell my patients, your pressure could be 50 the next day, it could be 2. We're gonna see the same day ideally, and then see the next morning. Watch it, maybe do a refill. And I've had some success in that. And sometimes you have to laser them after, because there's still a bit of a cleft closed. And sometimes you get burned because you close a nasal cleft, and there's a small contrecoup temporal cleft on the other side. We published that. So it's just a matter of being careful. And that's why I think intraoperative gonio, before and after you close the cleft and do 360 degrees looking around, is important in these cases. It's incredible how a small cleft, like even 1 clock hour, can cause hypotony.
Yeah, definitely agree. So, and the decision, I think there's no good or bad decision here. And even in the surgical planning, would you close the cleft and do the phaco after? If you decide to do both, maybe part of the soleal weakness is partially due to the cleft. I don't know. It's in my case, I decided to do the phaco first, but I think.
Can I have a question?
Yes.
In every patients that you combined, that you perform combined surgery, in which patients do you insert CTR? I mean, in every patient, you insert CTR or not? How do you choose them?
Do you mean, Zainab, CTR on the bag for zonular stability, or do you mean CTR on the sulcus?
Yeah, after performing a cyclopexy, direct cyclopexy and adding cataract surgery already. In error cases, would you put into sulcus CTR?
Sebastian, you go ahead and give your answer. I'll tell you what I think, and others too. Sure.
Well,
Or in which patients would you prefer to implant CTR in the sulcus?
my preferred approach, I showed you the video. That's really I'm more comfortable doing that direct cyclopexy there. And as we mentioned, depending on the post-op course, you may need to do a second procedure. Now, having done a direct cyclopexy first, what would be my second procedure would be probably a transscleral laser or diode or cryo that I would try if I would suspect that there would be some kind of a small cleft remaining. But if I would have to go back into the OR, yes, my second surgical intervention would be probably to do a cow itch around the CTR and then insert that in the sulcus and then guide the double mounted suture in the area of the cleft, just to reoppose to put some pressure.
You might not see the both edges. I mean, in those cases, maybe you can implant CTRs. That's what I think.
Well, if you implant the CTR, I think you have to stitch it, or you have to suture it in some fashion. Just the level of tension in the CTR by itself is probably not sufficient to create some reapposition of the cerebral body cleft.
I agree. I think if I was going to do a CTR with the ones we published, we suture them in. I don't know, Zainab, if I do both. If I'm doing a direct cyclopexy, I typically haven't done a CTR with it in the sulcus. I usually do one or the other. I don't know why. I guess I just figure I can do enough with one approach only. You know, I mean, we had one case where we sutured a Cioni ring, a double eyelid Cioni ring in the sulcus, and the patient started getting some pigment dispersion from the eyelid rubbing onto the back of the iris. So that's a theoretical concern, although I do like it. Don't get me wrong, I do like it. I generally go right to direct cyclopexy, and I don't typically combine it with the suture CTR. That's been my only approach. Of course, these aren't very common. I think our publication was, 30 patients or something, or 34 patients, multi-center, and you know, it's very much anecdotal.
When you're suturing the CTR for this purpose, how many fixation points are you doing? Like, how many sutures are actually?
Usually one. Usually, like where the area of the cyclodialysis is. If it's really large, then you could, because the double eyelid ring, really, remember the eyelids are maybe 180 degrees apart. So I don't think suturing it away from the cleft is really that useful. I typically suture it just in the area. You don't have to have, you can have it without the eyelid though. You can put a CTR in and, you know, do as Sebastian said, have a cow stitch hit on it and go through, or you just suture around the CTR. And I've used the endoscope to do that, to look at that. So that, you know, you don't have to have that double eyelid, mind. You can just put a regular CTR in.
I mentioned the cow hitch technique because I don't have endoscope, because it's hard to be over and under. So if you do outside of the eye, the cow hitch, and then you insert.
Pass a needle in.
Yeah.
Great.
I just want to add something for the iris fixation. If anyone in the audience is still interested in practicing their skills for like iris suturing or any IUL suturing as well, I showed the eye that we want to use is the simul eye. We're actually ordering some for us. And apart from getting that eye, it's called the simul eye iris suture or IUL exchange. That's the model that you should pick. Make sure that you also get a base plate, so to put the eye and stabilize it, as well as getting some surface coating gel just to optimize your view. So there are some available on the website. I know that I said they were sold out, but there is still some if you want to order.
Yeah, Stuart Stoll just messaged us and said, "Hey, we have some." So they're great. I mean, I think a lot of different artificial eyes are out there. There's certainly different brands. I don't want to say only one brand is the best, but I will say that Stuart has done a great job, you know, modifying and adjusting and making it as real life as possible with the stimuli. So I think that it's a great opportunity for people to do that. So I highly recommend that. Again, it's simuli.com. And I have no financial interest.
This really cool painting.
Yeah, me.
This is actually the angle. It's a watercolor painting. That's
wow.
Yeah, that's the angle. This is the vitreous, and that is your ciliary body. So I thought in honor of our talk, I should do this.
That,
I
that,
didn't
that
know.
was, that was post cleft closure. That was well
Yeah,
done.
right.
That's
It's by a
beautiful.
really cool artist. Her name is Lion Art, and she does all kinds of anatomical paintings. But I found one of just the angle, so I thought I had to buy it.
Very cool.
Mhm.
That is very cool. Zainab has a guitarist behind her.
And just for the maybe the people in the audience that don't know the cow hitch technique, you grab your suture, you do this, and you can put your CTR around, and that's how you tie a cow. So
That's right. Zainab, you had a comment.
Yeah, I would like to say something. As you said, it's very important to define the location and extent of the cleft, and it's kind of tricky work. I mean, the gonioscopy in those cases, in those hypotenused eyes, it's not that easy. So I do the same thing, inject viscoelastic in the anterior chamber. We should do that in every cases, because sometimes clefts might be hiding right behind the peripheral anterior synechias. This is very important. There might be small clefts just right behind the peripheral anterior synechias. So it's very important to fill the anterior chamber with viscoelastic during gonioscopy. It's very important.
That's a great point. That's a really good point, because PAS can actually mask a cleft.
Yeah.
Very true. Very, very true. It's a very good point.
It's, as we know, they are very common in post-surgical eyes or trauma cases.
and even if you tried argon laser also, instead of the laser hitting the cleft, if you hit the iris, then you can have a cleft behind that.
Yeah, that's why we should do that.
Well, great. You know what? It's been a great discussion. We had 3 great cases. We had I think it looks about over almost 1,000 people on YouTube that have been watching it at different times, and we had about 450 I think on Zoom. So you guys had a big group watching you here. So thank you for being part of it. Thank you for the attendees for being here. All the work that you guys have put together. Adrian, thank you, man, for great case you presented. I know that Gary didn't help. Gary was a distraction, but thanks for Gary for making it happen as well. From Ottawa, stay safe, guys. Zainab, thank you for being with us all the way from Turkey. And
yeah, it's great being here.
We pray that you stay safe and this pandemic passes us without many problems. Sahar, you've joined us again from California. I hear you guys are looking a bit better. I'm glad to hear that. And you always add some great comments in there, so thank you as well.
Thank you.
Valentina and Tiziana, thank you for helping us out on the iris suturing. It's important to hear from those that are starting their career in iris suturing. I'm sure both of you will probably agree how rewarding it is after doing this, and the satisfaction from your patients and from you doing it. I would probably say that would be something you probably have noticed. No, maybe not. I'm proud of you guys though. And Harry had to step out, but we thank Harry for being here. Harry's of course a giant in the field, so he was great to have on board. Sebastian, as always, thank you for your innovations and presenting with us as well. Jeb, do you have any last comments before we close? We always get a lot of people still staying on, so but we will close. It's past our time. Any comments, Jeb? Unmute yourself, man in black.
Sorry. So I mean, listen, at this point, there's so many webinars. We really do appreciate that you guys actually choose and come and watch the sessions that we do. There's a lot of work that goes behind it, but I think it's definitely been beneficial. And so far the feedback has been very positive. So trying to keep up the good work.
Keep up the good work, everybody. Don't forget to post a picture of you with your COVID hair, #COVID hair. We're supporting a group called conquercovid19.ca, which is basically a group that's supporting healthcare workers to get PPE and other equipment. There's been a gap, of course, and shortages. So it's incredible how people have come out of the woodwork and helped out in getting these equipment to people in need. And by sporting your COVID hair and not going out and getting a haircut, you're staying at home, which reduces the demand on our healthcare forces. So, of course, I've been practicing my COVID hair all my career now. So I'm just basically back pretty well normal, although it is very long now. So I think I'll probably keep it for a while though. So keep on staying warm and staying safe. And thank you all for being here. It's really great to see everybody. This is really what is the most warm part about doing these things is the camaraderie that we see here. I really think that the tragedy, of course, of COVID is well known, but the after effect or the effect of working together and being closer to each other by seeing each other and collaborating is incredible. I think we're gonna, I hope, come out of this strong, and we pray for those that are still struggling and those that are impacted, and we pray for your safety and for your health as well. And all of you still listening, stay in touch. We have another rounds, Jeb. We have it on Saturday at noon Eastern time.
That's right. And one thing is that the Saturday after, we actually have a very special one with involving Ike, kind of more like interactive surgical learning. Sophie's going to be there as well. So you guys should be.
Guest speaker, Sophia. You guys want to say hi to everybody?
Hi.
Say stay home and stay safe, right?
Stay home and stay safe.
And make sure your kids all do your homework and listen to their parents.
Make sure your kids all do their homework and stay safe.
Of course. Okay, everybody. Love you guys. Take care. Keep well.
There.
Bye-bye.
Bye. Okay, so